Hello, everybody. Welcome to the third online Turkey Society of Fertility Preservation Masterclass in Reproduction webinar series. I am Dr. Aylin Perinçil. I am one of the board members of Turkey Society of Fertility Preservation, and I'm going to moderate today's webinar. The main reason of doing these masterclass webinars in reproduction is to discuss the latest research on important topics, not to promote any of the techniques that is not evidence-based. Today, our main topic is new strategies for ovarian reactivation and therapeutic potential of bone marrow-derived stem cells in patients with diminished ovarian reserve and premature ovarian insufficiency. This is, of course, a very attractive area, and there are many new research ongoing lately to manage ovarian aging. Patients with diminished ovarian reserve and premature ovarian insufficiency are the most difficult ones in our IVF practice to manage. And those patients are vulnerable to exploitation to almost any technique that will increase their chance of getting pregnant. So I think it's important to highlight that the techniques presented in today's webinar are done for research purposes, and they don't reflect our routine practice. Our guest speaker today is Dr. Sonia Harei. She has a PhD, and she's currently the research group leader in EV Foundation. And she has done extensive research in this area of diminished ovarian reserve and premature ovarian insufficiency. And she's currently still working on the cutting edge research on this area. That's why we want to have her speak about her latest research. And thank you, Sonia, for joining us tonight for this webinar.
Well, I want to thank to the organizing committee for inviting me to give this lecture, and also to the Turkey Society for Fertility Preservation. Let me just share my screen. We are going to talk about the new strategies for ovarian reactivation and the therapeutic potential of bone marrow-derived stem cells for women with diminished ovarian reserve or premature ovarian failure or insufficiency. The last century was characterized by population growth, but this one is meant to be for population aging. Indeed, it's been estimated that by 2030, 24% of European population will be around 65 years old. This is especially relevant for women, as most of the human organs and systems start to show the first clinical signs of aging around 60 or 70 years old. However, the ovary shows a unique decline in the ovarian reproductive performance starting at mid-30s of a woman's life. Age associates decreased oocyte number, but also decreased oocyte quality, with increased aneuploidy rates, increased prevalence of genetic abnormalities, infertility, and miscarriage rates. However, age is not the unique or the only threat for the ovary, as we've got what we call the worst ovarian situation of women, young women with premature ovarian insufficiency, where the ovary lose the ability to ovulate and function before a woman is 40. However, it's important to highlight that even in this situation, when the ovary doesn't work, remains a residual pool of primordial follicles that hopefully can be rescued to growth. And we should put our attention in that residual population of dormant follicles. Indeed, the histological analysis of ovarian biopsies of POI women show that 39% show numerous or a few of these dormant follicles already present. The proof of concept of the ovarian rescue or follicular activation was published in 2013 by Kawamura, following a protocol composed by in vitro activation with PI3K and AKT stimulating drugs and ovarian fragmentation. They achieved this follicular rescue and live births after the in vitro activation and ovarian fragmentation in POI women with long-lasting infertility more than 6 years after the POI diagnosis, showing or proving that these residual follicles are able to grow and be ovulated in an adequate ovarian environment. The technique has been modified since first described by Kawamura through a less invasive technique based only on the ovarian fragmentation. This ovarian fragmentation allows the inhibition of the HIPPO pathway, which is a pathway that maintains the organ size. Once the pathway is inhibited in the ovary, promotes the secretion of anti-apoptotic factors as well as growth factors, which at the end promote follicular growth. This new approach, only using the ovarian fragmentation, avoids the use of ICAT stimulating drugs, reduces the number of required surgeries as the ovarian collection, fragmentation, and reimplantation of the tissue is made on the same surgery, does not require ovarian cryopreservation and therefore minimizes the cryodamage for follicles, also looks for the best vascularized site, and allows for natural pregnancy as the ovarian fragments are reimplanted in the ovary. Different studies have reported an overall cumulative pregnancy rate ranging from an eventual success rate of 30% pregnancy rate reported by Kawamura when first describing the technique in a well-characterized POI population to a 60% reported by the Andersen's group in women with diminished ovarian reserve, characterized only by low AMH levels. So this cohort is already mixing some POI and diminished ovarian reserve women. But it's been recently this year when the first randomized clinical trial has been published by using ovarian fragmentation in poor responder women according to Bologna criteria by Dr. Diaz Garcia from our group in EV London. Patients meeting the Bologna criteria for poor response were randomized to the surgery group where they receive the ovarian surgery, the ovarian fragmentation in one ovary, or to the control group with no intervention. The ovarian fragmentation resulted in an inhibition of the HIPPO pathway conferred by an 18.8% reduction in JAK phosphorylation, which is how we measure the inhibition of the HIPPO pathway and the secretion of these anti-apoptotic factors as well as growth factors. When the outcomes were compared between controls and the surgery group, we realized that ovarian fragmentation allowed an increase in the total antral follicular count when compared to controls, but also an increase in the antral follicular count in the fragmented ovary when compared to basal levels. However, serum AMH or FSH levels did not improve or did not modify after the surgery. When we compare the reproductive outcomes, we do not detect statistically significant differences between the surgery group and the control group, with a pregnancy rate ranging from 20 to 13.3%, meaning that these techniques, although promotes follicular development, is probably not useful for poor responders when diagnosed according to the Bologna criteria. However, I want to show you that many of the patients were not randomized to the in the randomized clinical trial because they were already POI. So they underwent the phase 2 of the study. They were 40 POI women, aged 35, 36 years old. In this specific subgroup of women, this ovarian fragmentation resulted in an inhibition of 27.7% decrease in the JAK phosphorylation, which is almost double what we observed in the previous group of diminished ovarian reserve women. And these 40 POI women included 7 pregnancies, meaning a 70.5% pregnancy rate, which is pretty high for POI. When we examine in detail the diagnosis of our patients, we realized that for those with a true POI, the pregnancy rate was as high as 7.1%. But for those specific women's diagnosed as fluctuating POI or intermittent POI, the pregnancy rate rises through 41.7%. So this technique, although it's not useful for POR or diminished ovarian reserve patients, seems to work very nice for this specific subgroup of young women with intermittent POI. These studies also corroborate this concept of follicular rescue. And we felt that this can also be the underlying mechanism of several reports of spontaneous pregnancies and fertility recovery in infertile women due to cancer treatments because they receive chemotherapy after receiving a bone marrow transplant. Indeed, the bone marrow-derived stem cells, the whole population, is composed by different mononuclear cells, including both hematopoietic and mesenchymal stem cells, all together with other progenitor cells. Thanks to the advances in hematology and oncology fields, they can be mobilized and produced to peripheral blood for collection via pharmacological treatments. We are always going to have an autologous source for use, and no cell culture is needed to assess enough cell concentration, which means that working with this specific type of stem cells is going to make the clinical setup easier to apply. In order to test our hypothesis, we first start our experimental design by inducing with chemotherapy in a mouse model the DOR as well as the POI condition. Once the ovarian damage was established, the animals were infused with these human bone marrow-derived stem cells. And we realized that these bone marrow stem cells, compared to normally circulating blood cells, were able to restore estrus cyclicity and estradiol secretion, even in the POI model, promoted follicular development and increased the number of preovulatory follicles, also increased after ovarian stimulation the number of ovulated M2 oocytes and the number of generated 2-cell embryos. And when we observed the effects on the long term, we realized that we're able to restore the long-term spontaneous fertility, even increasing litter size, during the long-term follow-up in the POI model. And all these positive effects mediated on the follicles and oocytes were mediated through the regeneration of the ovarian niche, where we observed increased ovarian local vascularization, increased cell proliferation, especially on the granulosa cells, and reduced apoptosis and atresia. But the mouse ovary is completely different to the human one, and sometimes we test things or cells in mouse ovaries, but they doesn't work in human. And that's why we include a second experimental step by xenografting ovarian cortex from poor responder women into immunodeficient mouse. Then we infuse the animals through the tail vein with the bone marrow-derived stem cells, and we observed that in human ovarian tissue from poor responder, these cells were able to engraft into the human cortex, close to vessels, and even in contact with granulosa cells, where promoted the development of human follicles, as we only detect secondary follicles in those grafts receiving the stem cells. And all these effects were again mediated by the regeneration of the human ovarian niche. We analyzed the human graft at both the transcriptomic and the proteomic level, and we realized that the stem cells rescue already existing follicles to growth by regulating different pathways related to FOXO signaling, which is one of the main effectors of follicular activation, apoptosis, and also longevity regulation pathways. Based on that, we start what we call our first pilot study in 20 poor responder patients defined by the ASA criteria to test the autologous stem cell ovarian transplantation, or the ASCO technique. The technique consists first on the mobilization of the bone marrow-derived stem cells by a 5-day treatment with granulocyte colony stimulating factor. Then the cells were isolated from peripheral blood by apheresis and infused into one ovarian artery by intraarterial catheterism, though the contralateral ovary served as a control. Then we perform a 6-month follow-up for the ovarian reserve biomarkers and an IVF study. And I'm going to show you the results that were obtained after the ASCO technique. First of all, we observe a high variability among patients for AMH because according to Bologna criteria, we are classifying older women with diminished ovarian reserve, but also younger ones with diminished ovarian reserve. But we were able to identify two peaks, as you can see here, of increase in the AMH levels, meaning that the follicles are growing and they reflect the follicular waves. Total antral follicular count significantly increased after 8 to 22 days after the ASCO technique, being especially relevant on day 15 after the stem cell infusion. Positive response was observed in 81% of the patient when considering this positive response as an increase in more than 3 follicles in the antral follicular count when compared to basal levels established prior to the technique, or an increase in AMH. But surprisingly, no difference was detected between the control and the infused ovary. And this maybe can be due to the fact that the positive response was correlated with the presence in plasma or in apheresis of two stem cell secreted factors, the fibroblast growth factor 2 and thrombospondin, a key regulator of angiogenesis, as the bone marrow-derived stem cells are adult stem cells, and one of the main ways of acting is the paracrine wave, which meaning that the cells secrete positive growth factors that stimulate the cells to grow. For the IVF part, we compare all the previous attempts that our patients did before the ASCO with those that were made after the ASCO technique, and we realized that AMH and antral follicular count were increased after the ASCO technique. More punctured follicles were achieved after the ASCO, altogether with a reduction in the cancellation rate, which is one of the big problems that we have in our clinic with the poor responder patients. Overall, our 18 patients performed 34 IVF attempts. Oocyte pickup was successfully developed in 85% of them. M2 were obtained in 76.5%. Embryos were generated in almost 65% of the IVF attempts initiated, and the pregnancy rate after IVF was around 9%. For a similar amount of cycles, we realized that the patients almost doubled the number of M2 oocytes and generated embryos. However, when we performed the PGTA, the euploidy rate was pretty low. It was around 90%, which corresponds to the patient age, as most of our patients were around 40. Seems that the ASCO technique promotes follicular development, but did not modify the embryo quality. Even though we obtained three pregnancies after embryo transfer, plus 3 spontaneous pregnancies in our patients. Overall, the ASCO allowed a pregnancy rate of 33.3% for older patients with long-lasting infertility and no other option than egg donation, because our patients in their previous attempts, even doing the same number of IVF cycles, they were not able to reach any single pregnancy. In summary, what we have observed in our experimental models and the pilot study is that the long-term fertility restoration occurs in the animal model, and several of our poor responders achieve spontaneous pregnancies more than 6 months after the ASCO technique. So the question to answer is, are we inducing any long-term effect? In order to answer this question, we collect plasma samples at the recruitment, on the day of apheresis, and 3 months after the ASCO, and we analyze these samples by a swab technique, which is similar to NGS, but at the protein level. Our results showed that there was a clear separation between the 3 conditions, with 23.6% differentially expressed proteins 3 months after the ASCO technique when compared to the previous state of the plasma. And the individual analysis of all these proteins revealed that the ASCO technique increased in plasma the concentration of some proteins that have been previously described as decreased with aging, while decrease the concentration of some others that increase as age advances. Again, we found the thrombospondin 1 upregulating 3 months after the ASCO technique. In summary, our results shows that the bone marrow derived stem cells secrete or release these soluble factors that stimulate the ovarian stroma and follicles to proliferate and grow. They were also, or seem to be also, able to reach by themselves the ovarian niche to make these positive effects, and seems to be a good option for poor responders, but can be also a good option for POI women. In order to answer this question, we start with what we call the second ASCOT study in a population of POI or premature ovarian failure women according to ESSE criteria. In this case, we established a maximum age of 38 because as we realized that the ASCOT did not modify embryo quality, doesn't make sense to produce embryos if they are going to be aneuploid. For this study, 20 women are going to be included and randomized to two different study arms. The first one is the ASCOT arm, where we are going to develop the technique as we did on the poor responders, meaning that the cells will be mobilized, collected, and infused into one ovarian artery, while on the second arm, we have called that one mobilization. The cells will be mobilized by a 5-day treatment with GCSF, but they will remain circulating in peripheral blood without cell infusion. Then we perform a follow-up for antral follicular count, AMH, menses recovery, etc., and IVF will be started when antral follicles detected. To date, we have included 10 POI women, 6 to the ASCOT arm and 4 to the mobilization. They are mean age 34 years old with pretty high FSH levels and at least 13 months of amenorrhea. Most of them, 90%, as you can see on the table, have also some vasomotor symptoms or menopausal symptoms associated to POI. But the study has been stopped for a while due to the COVID pandemic. But I'm going to show you the first results or the preliminary results that we have achieved in these 10 POI women. As you can see in the table, preliminary results show that more than 50% of our patients show follicular development and antral follicle well detected in 66% of patients included in the ASCOT and 50% in patients of the mobilization arm, allowing the initiation of ovarian stimulation in 60% total of patients recruited. These follicular growth waves were mainly detected 3 to 5 months after the technique, which makes sense with the rescue of primordial follicles, as this is the time that a human follicle requires from activation to the antral stage. Overall, we have obtained 12 M2 oocytes compared to 0 in their previous attempts made before the ASCOT technique. 3 embryos have been generated, 2 embryo transfers performed, 1 in each study arm. And for now, we have 1 ongoing pregnancy in the ASCOT arm that resulted in the live birth of a healthy child. But last but not least, it's important also to highlight that spontaneous menses recovery has been also reported in both study arms and an improvement in the menopausal symptoms that our patients show, which was not our main outcome for the study, but it's a good result that they also have this improvement of the menopausal effects, showing that this adult stem cell paracrine signaling can be also a less invasive approach, as positive effects have been also achieved after the stem cell mobilization without requiring the cell infusion. And talking about the paracrine signaling, let's start with PRP or platelet-rich plasma, which is also based on paracrine signaling. PRP contains a high concentration of platelets, which carry more than 800 types of cytokines, molecules, and growth factors, has been used for many years in different fields of medicine, such as sports medicine, surgery, or dermatology, and was proposed as a strategy for ovarian reactivation for POI women in 2016 by Dr. Pantos from Greece. PRP induces accelerated angiogenesis, inflammation control, cell migration, differentiation, and proliferation through the release of these positive growth factors and cytokines. As I mentioned, it was proposed in 2016, and most of the reports to date, or the publications regarding the use of PRP for ovarian reactivation, were case reports or a small series. But let me show you that in the last 2 years, the big series of PRP intraovarian injection just raised in the journals. Let's talk first about POI women. The Turkish group led by Kakigloru published in 2020 a series of 311 POI patients receiving intraovarian injection of platelet-rich plasma. And after this intervention, they report increased central follicular count, although AMH levels, although the FSH levels were not modified, but ovarian research biomarkers improved. This allowed them to initiate control ovarian stimulation in most of the patients, with 23 spontaneous pregnancies reported after the intraovarian injection of PRP. 57 embryo transfers have been performed, and overall they achieved 26 pregnancies, meaning 11.5% pregnancy rate for POI women, which is pretty high. But this result probably will be higher because authors reported at the time of publication 25 additional patients with cryopreserved embryos waiting for transfer. Similar results were published also by the Pantos group in 2020 in a series of 30 POI women with an overall pregnancy rate of 10%. In this case, all the pregnancies were spontaneous ones. And this is like the best result that we can achieve. But what happened for poor responders or diminished ovarian reserve? The result seems even better, especially in this study of the Pantos group, with 30 poor responders receiving intraovarian injection of PRP. They achieved 46.6% pregnancy rate. Then we've got the MELO publication. It's not a randomized trial, but they compare 46 poor responders treated with PRP with 37 controls, and they observe an improvement in ovarian reserve biomarkers, an increased pregnancy rate and live birth rates when compared controls with PRP. And finally, the last study, but I think is the biggest series to date, is the Kakigloru one, with more than 500 women diagnosed with poor response, in this case according to Poseidon criteria, where the PRP resulted in an improvement of ovarian reserve biomarkers as they detect increased antral follicular count, increased AMH, but in this specific group, they also decreased FSH levels. More oocytes were recovered, more blastocysts generated when compared to those IVF attempts performed prior to PRP injection. Overall, the poor responders in this study achieved a 20.5% pregnancy rate. But as I mentioned before, for this study, they use the Poseidon criteria, and the authors conclude that within the Poseidon groups, the Poseidon group 1, which means young patients with diminished ovarian, with unexpected poor response to ovarian stimulation, were the ones more benefited from the intervention. Indeed, they established a limit age for indicating which patients are going to be the most benefited from PRP injection, and they established that those younger than 38 are the ones that are expected to respond better after PRP injection. It's important to highlight that all these reactivation techniques show different results in poor responders and POI women, which means that there's not going to be a universal technique for everyone, and that's why we should carefully examine each technique for both different diagnoses. As, for example, with the ovarian fragmentation, we realize that it's not useful for poor responders, but works very nice for young POI women. And this is especially relevant when talking about POI populations because the POI spontaneous pregnancy rates across studies range from 2.2 to 14.2%, which is a big difference. And this is especially due to these fluctuating FSH or intermittent POI women that were described by Bachelot in 2016. And is that specific subgroup of POI women where spontaneous resumption of ovarian function occurs in 25% of these women during the first year. Further research is still required, as highlighted by Atkinson in this paper published in Human Reproduction, not only for PRP, but for all the techniques that we are testing to properly identify which population of women is going to be the most benefited, which technique is working for each type of damage in the ovary, but also to understand the mechanism. We also require research to establish less invasive and more effective treatments, and maybe the answer will be on the combination of different techniques. Based on that, we published in 2021 this paper in the American Journal of Obstetrics and Gynecology, where we try to test the combination of different sources of stem cell secreted factors from the bone marrow and from the umbilical cord blood alone, but also in combination with PRP, meaning with those additional growth factors that are enclosed in platelets. We test all these combinations in our diminished ovarian reserve and POI induced models by chemotherapy on the long and short term. Our results show that the stem cell soluble factors secreted by the bone marrow-derived stem cells, but also the umbilical cord blood, promoted follicular development and rescued long-term fertility in chemotherapy-induced ovarian damage mouse models. However, the highest effect, or the most potent effect, especially when examining the cumulative pregnancy rate, spontaneous ones, I mean, in the long term, were achieved with, as you can see here, with the combination of bone marrow-derived stem cell factors and platelet enclosed factors, reaching pregnancy rates similar to wild-type animals. But these are chemotherapy-induced mouse models, which are pretty different from what we observe in aged women. And that's why it was presented in the last SRI meeting in Denver. We also test this combination of the bone marrow-derived stem cell secreted factor and the PRP in a physiological aging mouse model. And we realized that this also works in this type of damage, which is encouraging. When we analyze all these plasma sources containing different growth factors by the SWAT techniques, we observed that the fraction that was reached in the bone marrow-derived stem cell and the platelet enclosed factors showed the highest percentage of upregulating proteins, including some related with the DNA damage recognition and repair. This is very important because most of the aneuploidies are due to DNA damage accumulations on the oocyte. And this is why we validate this specific treatment in human ovarian tissue from poor responder patients, where we realize that this treatment also promotes follicular development by regenerating the ovarian meat. In summary, this plasma provides specific proteins related to dormant follicular activation, DNA synthesis and repair, cell cycle checkpoints, cell proliferation, and angiogenesis, among others, that when injected into the ovarian tissue promotes the rescue of dormant or already growing follicles by improving the ovarian needs, and all these effects are mediated through the upregulation of specific proteins in human ovarian tissue related to follicular activation, but also markers of oocyte quality, which is very important because to date, none of the techniques seems to have an effect on oocyte quality. Also provides protection against apoptosis, cell proliferation, and intervenes in the folding of receptors for LH and FSH. Based on that, we are going to test this technology in a randomized clinical trial with a control group in a POI population of 42 women. We are developing this randomized clinical trial right now. Hopefully next year we will show you the results of the intravariant injection of this combination of the bone marrow-derived stem cells and platelet-enclosed growth factors. Because this is where we are now on the pathway to ovarian reactivation. We rely on control ovarian stimulation protocols, PGTA, and oocyte donation. In the last years, we realized that the ovarian fragmentation works for young fluctuating POI women. The ASCO technique, it's a good option for poor responders. We are working to a technique simplification and also checking if it works on POI women. We have proposed also some treatments based on plasma, not only PRP. But it's important to highlight that we should keep in mind that most of these techniques are focused on reactivating follicles and promoting follicular growth. But quality, it's a big issue, especially for aged patients. And that's why we also should work on developing cell repair techniques, maybe focus on telomere length, DNA damage, or oxidative damage, which is considered one of the main threats for the ovary, because the demand of ovarian reactivation techniques is increasing both in the diseased and healthy ovaries due to postponed maternity to advanced maternal age, when both the quantity and the quality of oocytes is low. I want to say thanks to my colleagues from EBRMA, EB Foundation, and Hospital La Fe for doing all this work, especially to my mentor, Professor Pellicer. And now I will be more than happy to answer questions if there's any. Thank you very much.
Thank you, Sonia. Thank you for this very interesting, encouraging, and very good talk. And thank you being with us tonight. And those research studies that you have done are really amazing. And what amazes me most is that you started with the mouse models and then just show some improvement in those, and then you just moved on to the human research, and then you just again find something and then again tested it on the mouse, and now you're again planning new techniques, and this is so encouraging, and thank you.
Well, thank you very much for, as I say at the beginning of my talk, for giving me this opportunity to show you what we are trying to do at EB Foundation from both the basic science side and the clinical one. So we felt that we should keep this path, starting to test our hypothesis at the lab with animal models, with in vitro experiments, before to move to the clinical setup.
Yes, and those are, I just want to mention again and highlight that those are the research, those are done in the research setting, and none of these are our routine practice. But I hope in the future we will have evidence-based data and help either young premature ovarian insufficiency patients and maybe older patients. And so there are lots of questions for you here. And first, I want to start with, okay, stem cells might be obtained from adipose tissue, menses, etc. Why did you choose bone marrow stem cells for your research?
Well, we choose, I know that there's other groups working with the adipose stem cells or the menses stem cells, but in our hospital, we have a close collaboration with the hematology unit. They have a lot of experience on doing bone marrow transplants, and we were, when we were searching for when we start all this stem cell project, we realized that there was on the literature many reports of spontaneous pregnancies, as I mentioned on my talk, and fertility recovery in infertile patients due to chemotherapy after receiving a bone marrow transplant. And that's why we felt that we should start there. And especially because thanks to the advances of the hematology and oncology fields, right now you can produce and mobilize significant cell number of bone marrow stem cell by a pharmacological treatment, for example, with GCSF, which is the protocol that is being used worldwide for bone marrow donors. So it's a safe treatment, has been tested for a long time in other fields. And this allows the collection of the stem cells from peripheral blood. So we do not require this invasive iliac crest puncture. And also because by using this protocol, we do not require to further stem cell culture to reach enough cell numbers, because it's been shown that when you culture for a long term, the stem cells, they can accumulate some genetic abnormalities, or they can lose some of their stemness properties. So we are trying to thinking on the future, on the clinical application. So we are trying to find the type of cells that can be easily collected, that can be an autologous source always, because if you work with menses stem cells and you are a POI woman, you are not having menses. So you don't have your own stem cells. And for the clinical application, it's easier when you are using an autologous source, because you don't need to check all these immune compatibilities, etc. So we are trying to reactivate the ovaries, taking advantage from what the oncology and hematology fields had made for many years, but also always thinking on the future clinical application. Because if at the end you make something which is very, very difficult and requires cell selection, a donor, cell culture, it's not going to be applicable in any hospital or clinical setup worldwide. And we made many tests in our animal models, even with the specific population of the bone marrow-derived stem cells. And we realized that the most potent effect was observed when we were using the whole population. And it makes sense, because when you take the whole populations, you've got mesenchymal stem cells, hematopoietic stem cells, also immune cells, pericytes, which are important for forming blood vessels, but also many other progenitor cells. So you've got like a broad spectrum of cells that can stimulate vessels, stromal cells, follicles, and have more effects than only selecting one population.
Okay, that's why in, for example, Asherman syndrome research, they use the hematopoietic stem cells, but you prefer to use the whole population because it will be better for the ovary to have them both all.
Well, when we start all this stem cell thing, we were based on that Asherman therapy. And in our first paper published in the animal model, published in Fertility and Sterility 2018, we compared the effects of the whole population with this specific CD133 positive cells. And we observed that the effects were pretty much higher using the whole population than only selecting these specific cells. And that's why we decide to use the whole populations, because the effects are better than with a specific subpopulation of cells. And then we move to the pilot study in patients.
And okay, it's interesting. In your first ASCOT study, you just injected the stem cells to the intraovarian, one of the intraovarian arteries, and you see that by the paracrine mechanisms, the other ovary also responded, right? And then you just moved to just mobilize the stem cells and then take them, and then just instead of just giving
Inject,
the,
yeah.
giving the injection, you just prefer to do just prefer to just mobilize them and then see the results. And
Yeah,
in the
well,
long term, you saw that it's the same, right?
well, it's not exactly the same, but it's also promoting this follicular development. And the fact is that when you made this 5-day GCSF treatment, the cells start to proliferate into the bone marrow and then mobilize to peripheral blood. But it's a progression, means the cells do not appear and then a second after they disappear. It takes like 5 days to reach the highest concentration, and then they start to decrease. So the cells are circulating. And the bone marrow stem cells, as adult stem cells, had this paracrine mechanism of action as one of the main mechanisms to do the effects in any tissue. And we realized that the positive response observed on the what was supposed to be the control ovary in the first study were due to this paracrine signaling. So we were thinking about, let's check if the ovarian infusion of the cells is required, or if we can have, by only mobilizing the cells, have positive effects, because this is a less invasive treatment, which is better for our patients. Because in our animal studies, we saw, because in the animal model, even when using xenografted human ovarian cortex, we inject the cells through the tail vein of the mouse, and they were able to engraft into the ovary and to proliferate there. And because for the animal experiments, we use a cell label, so we can track the cells, where they go, where they establish, and we realized that they went into the ovarian tissue. And this is what is happening during this mobilization. And this is the explanation of the positive results that we have seen in this second ASCOT study in POI women, comparing the former technique with cell infusion with only mobilization. So we are also having, well, we have not finished yet that study, so we should wait until the last patient is included. But our preliminary analysis shows that by only mobilizing cells, we are able to make the follicles grow and have M2 oocytes for when we perform the ovarian stimulation in these patients.
And in your next study, you prefer to combine PRP with the bone marrow derived stem cell therapy?
The thing is that we are always, even if we are working with patients, we are thinking on what's next, or what can, because right now, I think that one of the problems is that none of the techniques has shown a proper effect on embryo quality or oocyte quality. And we know that there's many older women, I mean, older than 38, that they require these techniques. And these techniques, for now, they promote follicle development, but they do not modify the quality. As much M2 oocytes you collect, you have the chance to get the good embryo. But we need to also try to fix the quality. And based on that, that's why we start to try to combine both the stem cell factors from different sources of stem cells with the PRP factors, to trying to find something that also improves quality. And this manuscript that was published in the American Journal of Obstetrics and Gynecology show us that by combining the factors secreted by the bone marrow-derived stem cells with the platelet-enclosed factors provides some specific proteins related with DNA repair, which is one of the main problems for H oocytes, that they do not properly repair the DNA damage. And that's why we start to walk this path through to find something that also modifies or improves oocyte quality.
Uh, and you didn't mention about the latest RCT on PRP, because at this year's ASRM in 2022, Dr. Sally and IVI group and um, Acıbadem group, they just presented their RCT results, and then they showed that they did not show any improvement in the PRP group for mature oocytes, and for other secondary outcomes such as clinical pregnancy rate or live birth rate.
Mhm.
So I think this is the last research, because in the biggest pro, prospective studies, they concluded that the most beneficial group will be the ones that are all younger than 38. And then in this randomized control trial, they try to show if those patients younger than 38 will benefit from PRP injection, but they did not see any benefit from PRP.
Yeah, the table that I show only comprises already published papers, because
Yes.
not everyone has access to this to the abstract of the SRAM conference, and that's why I tried to highlight during my lecture that we still require basic research, but also properly designed randomized clinical trials. And hopefully we will see Professor Sally's paper published in the next months, and we can have the whole picture of this data. Because sometimes the thing is that when you compare your papers or your therapy, your patients before and after a technique, you have this cumulative effect of stimulating too many times the same women. So it's not like the best control for this type of technique. But I realize even in my studies that sometimes it's hard, especially with POI women, to design randomized clinical trial, because when you say to someone which is diagnosed with a POI, you can be allocated to the non-intervention arm, they refuse to be included. So sometimes we need to balance in between what we want from the scientific point of view to what we can do. And we will see in this, because this randomized clinical trials is in poor responders, what's the real effect of PRP when compared with a properly designed control group. Because what seems from the previous papers that I show on my table is that PRP is also promoting follicular growth, but maybe we are not seeing any difference as it happens on the ovarian fragmentation for poor responders when we check the outcomes after ovarian stimulation cycle, which is at the end what we want. The patients do not want to get follicles, they want to get a baby at home. And this live birth rate should be our main outcome in the studies. But sometimes, it's hard to wait for more than a year to publish anything. So we
Yes.
will see
Yes, of
Dr.
course.
Selly's results, and we can examine in detail if there's any effect or not of PRP on follicular growth or endocrine levels, apart from what they describe, that they do not observe any improvement when comparing the number of metaphase 2 or embryos obtained in the control versus the PRP injected group.
Yes. So, and it's important to mention, as you mentioned, it's important for us and for the patients to know that those are not evidence-based results, because most of the results are in mixed patient populations, and so it's important to highlight which group of patients will benefit from each different technique.
Approach.
Yes, and as you mentioned in your talk, So we should be very careful when offering these promises to patients, because maybe and also there might be, those are invasive techniques and there might be some complications, and this will not be good for the patients. There is another question. Have you come across any acute or long-term side effects after infusion of GCSF for 5 days? Should we follow the patients for any serious side effects, or is it relatively safe to offer mobilization treatment to patients with POI?
Well, in our case, in the study, we are working in collaboration with the hematologists, the ones that work every day with people that are donors or it's for autologous source. So they treat patients with GCSF, which is the established protocol to bone marrow healthy donors. So we are using the same protocol. We need to carefully examine our patients, all the blood parameters, platelet counts, etc., before and after the GCSF treatment, because this is a safe treatment. We should administer following the rules of each country regulatory agency for drugs and pharmacs. And in our case, we didn't see any adverse effect after the administration of the GCSF or even after the ASCO. So we have not reported adverse effects, but it's something that the patients cannot take by themselves. So they should be monitored in the clinic before, during, and after the mobilization. They can experience some headache or some pain for a days, but they are described as normal effects from the granulocyte colony stimulating factor treatment, but we do not report any adverse or side effect in our treated patients.
Okay, and I want to ask a question. Do you think doing the bone marrow stem cell mobilization with PRP might be more effective, because the PRP is an invasive procedure, so it just promotes the bone marrow cells, the migration of bone marrow cells to the ovary? Do you think that doing an invasive thing to an organ might increase the mobilization of the stem cells to there?
Well, what we are testing on that randomized clinical trial that I just present on one of my last slides, what we are injecting there is not the stem cells. We mobilize the stem cells, so they are circulating, they are secreting these growth factors to blood. So we are working with that blood which is already rich in the stem cell secreted factors, and then we made the PRP. So we are injecting plasma, rich in the growth factors of both the stem cells and the PRP. Talking about if doing an injury on the ovary can increase the engraftment of the circulating stem cells into the ovarian tissue. From the biological point of view, when any stem cell in any organism detects damaged tissue, this damaged tissue secretes cytokines, pro-inflammatory molecules, and it recruits all the repairing mechanisms in a human body or in a human, in any life being, so in any organism. So there's a scientific basis for thinking that this can make sense, but we have not tested that on the ovary. So we cannot make this connection and say, okay, if I just make the injection, it's going to be better. We need to test it.
Because when you do the mouse model by xenografting, so you xenograft the ovary and then you just do the tailvein injection to give the
Stem cells.
bone marrow stem cells. The stem cells just go to the ovary. Maybe
Yeah.
because
Yeah.
there's an injury there, but when you do it in the human, if you don't
Mm-hmm.
do an injury to the ovary, so it's not
Well,
the same thing when you
well,
do
the
it
thing is,
in the mouse and when you do it. I'm not.
yeah, but yeah, I know, I see your point. But in the first paper, we made first mouse ovaries. We damage the ovaries, we inject the stem cells, and we see the cells going there. Then we made a second step, which was taking a biopsy of human ovarian cortex from poor responder women that were xenografted into an immunodeficient mouse, but it was human tissue. And then we inject the cells through the tail vein. As we label the cells with rhodamine B, we were able to monitor where the cells were. And we realized that the bone marrow cells were engrafted into the human ovarian tissue. Then we start to search on the literature, and it's been described that the bone marrow stem cells have a tropism for the ovarian tissue. It's called like the homing effect. I don't know if it's for any type of stem cells, but this one has this effect. And this can be one of the reasons why the cells work by themselves without inducing any damage into the ovarian tissue. And if we think about damage, any ovulation, it's considered a damage.
Yes, you're right.
So maybe we don't need to make anything else on the
Yeah.
ovaries.
Okay, thank you. Yes, you're right. Okay, we have another question. Do you think it would be beneficial to administer GCSF for 5 days several times with 2-3 month intervals? That was the thing I asked you before the webinar. So, do we
Yeah.
need longer and intermittent bone marrow stem
Well,
cells?
the thing with GCSF is that according to the International Society of Hematologists, and I cannot remember the whole name, you cannot give GCSF every month to a patient, because even if it's only a pharmacological treatment, it's not only like paracetamol. So we need to monitor our patients, check the values of all the blood parameters, especially taking in account the platelet counts, and we need to leave the organism to go back to normal, because our body is not used to produce too many stem cells every month. If we think about that, the normally circulating number of bone marrow derived stem cells in peripheral blood is in between 0 and 1 per microliter or per milliliter, I cannot remember. But by doing this GCSF, we are reaching levels of 50 per microliter. So that's not a normal situation. So it's an stressor for the body. We cannot use it every month. In fact, according to the recommendations for bone marrow donors, they need to make a rest in between mobilizations. So this should be checked in any country what the legislation says about that. So we cannot give, because we are using the same dose that is used for bone marrow donors. So this need to be checked with the regulatory agency of each country.
Yes, thinking about all you have described, the longevity of all these things is important, maybe because we can just have the results, but then the effect is gone. But if we may keep, for example, the vascularization for a long time, or other factors for the ovary, maybe the ovary will be more reactivated and the longevity of the ovary will be more. But how we are going to do this, is important. So what's your
Yeah.
future directions on these? And I know that you have promise on uh, resolving the aneuploidy issue too, as I
Yeah,
understand.
I didn't promise that. I will do my best, but I didn't
Yes,
promise.
yes, but what's your future directions? Because we don't have time, but I just want your
So
opinions
I think
about
that
the direction.
we need to check, as you mentioned, if only one injection is enough, if we need more injections, and how long, or how many injections, and how long should they will separate it in time. I mean, because what we see with the stem cells is that in our poor responder studies, I think that all the spontaneous pregnancies were achieved more than 6 months after the stem cells. So seems that once the, at least in poor responders, once the ovaries reactivates folliculogenesis, it's the effect is maintained in time. Because, for example, there's 3 spontaneous pregnancy. 2 of the patients get one pregnancy by embryo transfer, and the second one was a spontaneous one, while the third one was a spontaneous one more than 6 months after the ASCOT. And that's why we check if there's something that has changed on the plasma proteome, and we see many differences. So, but in POI, it's different because we need to reactivate those dormant follicles, and they take longer. They take at least 4 to 5 months to reach the antral stage. And maybe the thing is that we need to increase this follow-up period, because the first dormant follicle that has been activated will appear like 5 months after the technique. And we are expecting them to appear 2 weeks after the technique. And this is not biologically possible, because a human follicle takes 5 months to reach the antral stage from the dormant stage.
So we need
So
longer
we
follow.
need, there's many, longer follow-up for POI women, and further research to evaluate all these possibilities, not only checking every specific technique, but for example, with PRP or the techniques that are based on the injection of growth factors, how many injections, the interval for the treatment, and to check every outcome for both POR and POI, because they are completely different.
Yes, and you also mentioned fluctuating POI patients
The fluctuating POI,
who
yeah.
are going to most be benefit from this
Yeah,
tech.
this study shows that within the POI populations, these young fluctuating POI women are going to be like the most benefited, at least from what we have seen now.
So we have to be careful on selecting patients in the research setting too.
Yeah, yeah.
And there is another question. When would you expect the mobilization treatment to show any positive effects? But you have already answered. When should we call the patient for controlled ovarian stimulation after mobilization? Should we monitor the patient for antral follicle count and start treatment accordingly?
Well, this is different if we are talking about poor responders or POI. For poor responders, in the ASCOT study, we saw this first follicular wave growth 2 to 3 months after the stem cells, because in that case, we were rescuing secondary follicles that otherwise will undergo atresia, but these stem cells regenerate the niche, so they reach the antral stage. So the first response that we have seen in our studies in poor responders is like 2 weeks after the 2 to 3 weeks after the mobilization. And then you can see all these follicular waves. But in POI, if we are with a true POI patient rescuing or activating primordial dormant follicles, the follicular waves will start appearing like 3 to 4 months after the intervention. What we are doing now within the clinical studies is to do an antral follicular count every 2 weeks to be sure where the follicles appeared and when we can monitor them. And also because we have seen that there's no a specific pattern that is met by every patient. Because you can see a POI women that you don't know that it's a fluctuating one, so you can see any antral follicle before these 5 months. And that's why after doing all these techniques, we need to carefully monitor all the ovarian reserve biomarkers.
Yes.
To have the stimulation initiated once the antral follicles appear. We cannot miss any follicle for those women.
Yes. Okay. Thank you, Sonia.
Thank you,
All
Eileen.
are finished, and I'm really thrilled for your work and to have you here. I hope we will also invite you for other webinars or meetings.
I'm honored to join you.
Yes. Okay. Thank you so much.
Thank you very much. Bye-bye.
Bye.